Good afternoon. I'd like to thank Dr. Adonianakis and Dr. Brilakis for their kind invitation. It's a great honor. Most of you, looking at the title, probably think that we're bringing them coffee or fix the lights or put beautiful music. It's not like that. We're trying to make the best for the patient and the best for our surgeons. So, the key points. What are we trying to do inside the operating room? Before getting into the operation room, we have to take an interview, a very, very detailed interview from the patient. Inside the operating room, the airway management, which is always our job, positioning of the patient, a clean surgical site for the surgeon, intraoperative management, pain control, and quick discharge of the patient. So, 1 or 2 days before the surgery, we must come in contact with the patient because he has got many questions. One of them is, how much pain should I expect? What kind of medicines you are going to use, even though if they're not doctors and they're not familiar with the medicines. What does the pain management protocol begin? What kind of protocol do you have? There are many questions that we have every day. It is very important to have this patient interview because he's going to share his or her worries. We are going to offer reassurance. We are going to learn details that in most of the times they do not even reveal to the surgeon because of the fear they feel about anesthesia. So we are going to help the patient and the surgeon to have a plan of the surgery, and when we have all the details we need, we're able to check and handle the comorbidities of the patient. So, airway management. This is our main worry at the start of the surgery. We usually, in our hospital, use general anesthesia for that kind of surgeries, with either a tracheal tube or supraglottic airway. We have to be very careful with the airway management, not just with the management, but when the surgery is over and we have to extubate. There are many cases that we have got a very severe edema after the arthroscopy, even if it is in the beach chair position or not. So before extubating, we were going to use an anti-Tredellebuck position, wait for a while, maybe half an hour, use Lasix or other substances that were going to get the fluid away from the airway of the patient. Positioning of the patient. It's very important to have the patient safe. After general anesthesia, the tube is secured, as we said before. Both shoulders are examined for range of motions by the surgeons. The patient is then turned over or is put in a beach chair position. Lateral decubitus position. We have to stabilize the head very carefully and put a cushion, a pillow between the legs of the thighs of the patient, and be very careful with the pressure points. A soft sheet is rolled into a cylinder under the upper thorax in order to minimize the pressure on the neurovascular structure within the axilla. Pillows are placed between the legs, as we said before, and kidney rests are useful to support the bean bag if there is one. And broad adhesive tape may be have to use in order to further stabilize the patient. Adhesive tape is also used in the eyes of the patient because it's very important not to traumatize them. An electrosurgical grounding pad is placed over the muscular area of the patient. We said all the others. This is a beach chair. The sitting position is very difficult for us because the head must be very well stabilized in order to secure that the surgery, even though the surgery is going to get along very well, but we don't want the patient to wake up and not be able to move his or her arm. So, we need a clean surgical site for the surgeon. We do that by controlling the blood pressure. This is what we mean by saying making the lives of surgeons easier. When there is less bleeding, there is high speed of performance of the surgeons, less volume of intra-articular fluid, less edema, less pain, less opioids afterwards, and less time to discharge. In that position, in the beach chair position, when the blood pressure is very, very low, there is a very, very important problem with the brain of the patient. Maybe there is a possibility that he may not wake up very, very easily. So we have to respect the brain, keep a blood pressure in order to keep the blood into the head, the blood circulation. Another intraoperative management, hypothermia control. The surgeons need low degrees into the room, into the operating room, in order to perform better, but the patient must be warm because of the better healing that causes. Warm IV fluids for the patient, warm air close to the patient's feet. We have to prevent thrombosis, use elastic knee-high socks, and Flowtron, which cause pressure to the legs of the person in order not to have thrombosis. Control of nausea with dexamethasone, ondansetron, droperidol, IV fluids, and increase oxygen consumption. Pain management. In our hospital, we use general anesthesia, and we're trying, as Dr. Isaiah told before, not to use many opioids in order to have a quick discharge. So we mainly use intra-articular anesthesia, and the IV opioids we use are about 100 to 150 micrograms of fentanyl and 2 grams of paracetamol. Intra-articular analgesia involves not opiates. We don't use opiates. We use ropivacaine, 7.5%, which we warm it. This is our protocol. You're going to see it in a while. Bicarbonate, 4%, a very, very small amount. And tranexamic acid, a gram. This is our protocol. Tranexamic acid is, we usually use it for inhibiting fibrogenolysis, so stopping the bleeding, yet it is found that inside the arthrosis, it's helping us to better heal the arthrosis. In our protocol, we use as a control the VAS scale, the VAS analogic pain scale. So this protocol was sent as an e-poster to the Military Medical Convention in 2018. It was about 100 patients in our hospital only. In 69 of them, inside the arthrosis, were used the mixture of the 3 substances I said before, and 31 of them just the naropain, the ropivacaine. Most of them were of ASA 2, which means they do not have severe problems of health. And what we found in awakening, when they woke up in the operating room, most of them, the red is the ones that we used the 3-med mixture inside the arthrosis, did not feel pain at all. They had got a VAS scale of 0. In the recovery room, about half an hour later, the ones that used the 3-med mixture, most of them had to about 3 or 4 VAS scale, which means I feel a very, very light pain that doesn't stop me from doing other things. After 24 hours, the ones that used the 3-med mixture also didn't feel a lot of pain, about 2, and a very, very small number of them felt number 4 VAS scale. After 7 days, it was approximately the same things as we saw before. So, using this protocol helps us to discharge patients faster, make our surgeons happier, and make the patients happier too. Thank you very much.